Tremendous pleasure. Great to be here. I want to hope everyone's having a fantastic evening. And again, this is a tremendous. So let's begin our discussion on Cerianna. So this is the disclaimer, just for everyone to know that this information communicated during this presentation is intended in good faith and fair balance. This information should not be copied or shared without express permission from Xianexa or GE. In terms of the important safety information, indications and usage for Cerianna. Cerianna is indicated for use with PET imaging for the detection of estrogen receptor positive lesions as an adjunct to biopsy in patients with recurrent or metastatic breast carcinoma. With respect to limitations of use, tissue biopsy should be used to confirm recurrence of breast carcinoma and to verify status by pathology. Cerianna is not useful for imaging other receptors, such as the human epidermal growth factor receptor and the progesterone receptor. There are no contraindications. So let's begin exploring how Cerianna can uncover the unmet need in breast carcinoma. So let's talk first about status in breast carcinoma. PR, and HER2 status in breast carcinoma helps guide clinical decision-making. Biopsy to assess receptor status may not always be feasible in metastatic disease. While breast tissue itself is very easy, relatively easy and safe to biopsy, metastatic breast carcinoma lesions may be in sites that are very difficult to biopsy, such as the brain, or pose challenges for IHC analysis, such as a bone, specifically related to decalcification. Collecting a biopsy sample from metastatic tissue is associated with potential risks to the patients. So as a result, clinical decisions are often based on single location biopsy results. However, status may be discordant between lesions within the same patient, and this may be true for PR and HER2 status as well. So ultimately, a single biopsy may not be representative of characteristics of the tumor burden from all metastatic lesions as a whole, as demonstrated on this cartoon, which demonstrates one lesion that we know is positive. The remainder of the lesions, we just don't know what their status is. So let's talk a little bit about discordance. Expression may be discordant both within and between lesions. For that, we're talking about intratumoral discordance, which is within the same lesion, or between lesions. We know that patients with positive primary breast carcinoma may eventually present with negative mets. This may occur naturally or subsequent to endocrine therapy. Studies indicate that endocrine therapy is effective in only about 50% of patients with historically positive breast carcinoma that develop metastatic disease. The lack of expression in metastatic breast carcinoma correlates with disease progression with endocrine therapy. So status may be discordant between the primary tumor and metastatic lesions in up to 30% of patients with metastatic breast carcinoma. So let's talk about this unmet need. So while 70% of tumors express at diagnosis, not all patients respond to endocrine therapy, and some patients with disease that initially respond become refractory. The unpredictable response and acquired resistance to ET or endocrine therapy may be attributable to tumoral discordance. Again, the types that we described, intra, inter, or temporal discordance, which is change over time of an so moving from positive to negative. Because status may be discordant with the same patient, a single biopsy may not be representative of characteristics of a whole body tumor burden. Expression of a patient's disease may also change naturally over time while following therapy. Clarifying the extent of within-patient discordance may be critically important for decision-making. So let's talk more about Cerianna. It is, in fact, a very unique receptor-targeted molecular imaging agent. So let's take a look at the molecule and its mechanism of action. So first, estrogen receptors are overexpressed in about 70% of all breast carcinomas. The most potent endogenous receptor agonist is estradiol. F18 is a fluorinated estradiol molecule that binds to estrogen receptors, enabling visualization of expression when used with molecular imaging. The uptake of FES, or fluoroestradiol, in tumors, measured by PET scan, is directly proportional to expression measured by in vitro assay of lesions. And here's a wonderful depiction of the molecule itself. And here's a breast cancer cell. We see the FES molecules binding to the receptors. Let's talk a little bit about image interpretation, but with an emphasis on normal physiologic distribution. So when we acquire Cerianna PET, the patients are always positioned supine with arms above the head if feasible. The dose is between 3 and 6 millicuries. Uptake time is 20 to 80 minutes, but 80 minutes is recommended and what we are performing in my practice. With respect to the physiologic distribution, very importantly, the critical organ is the hepatobiliary system, the critical organ is the liver. And we also see radiotracer distribution, of course, to the bowel, the heart wall occasionally, kidneys, bladder, and physiologic organs like the uterus. The uptake within tumor depends on ER density, and this is true for specialized molecular agents like Cerianna. But again, understand that you may see physiologic uptake in ovary and uterus. The radiotracer is metabolized within the liver and is excreted predominantly by the biliary system with a smaller component of GU excretion. The one component I always like to mention to anyone when they're looking at a Cerianna study for the first time, and this is an example just of a MIP coronal images, there's two striking critical observations are that there is absolutely no uptake in the brain. So different from an FDG PET CT scan. But what may be just as similarly striking is the absence of any uptake within the breast soft tissues. So pretty remarkable that, for an agent that's estrogen specific, we see nothing in the breast. Incredibly helpful for reading the exams and performing these exams. Let's talk a little bit about the differences between FDG PET and Cerianna. So FDG, as we know, F18 fluorodeoxyglucose, is a radio-labeled glucose analog that assesses glycolytic activity, but is not a cancer-specific PET tracer. So not only does FDG pick up cancers other than breast, potentially in an FDG PET CT, but it may also demonstrate metabolic uptake in things that are non-cancerous, of course, inflammation, infection most commonly. FDG is suitable for assessing hypermetabolic disease, but may perform poorly for detecting indolent tumors, such as invasive lobular carcinoma or well-differentiated estrogen tumors. FDG does not assist in hormone receptor analysis. So let's look on the comparative at FES PET. Well, FES PET is a radio-labeled estrogen analog that specifically targets the ER receptor. FES PET scans and they measure regional estrogen binding, identifying lesions that overexpress ER. And FES is not useful for imaging other receptors, such as the HER2 receptor or the progesterone receptor. And as we said before, areas that have a high activity secondary to excretion, specifically the liver and the urinary system, are challenging to evaluate with FES PET. So let's take a look at these two images of the same patient who has an FDG and an FES PET. The image on the right demonstrates uptake within the axilla and some volume of disease within osseous lesions. Now, comparatively, we look at the FES PET. First and foremost, I'll mention that we see some radiotracer uptake within the vein, and that's typical for FES. No uptake again in the brain, and notice that there's no uptake within the breast. But notice that the volume of disease throughout the marrow or within the skeletal system is significantly more than what we were able to identify with FDG PET. Similarly, we see that there is uptake within nodes, but we see more of those nodes. So this is an example of a concordant FDG and FES PET with more disease demonstrated by FES than FDG. Let's take a look at Cerianna's mode of action, and we'll discuss from a background perspective Bohr's study in 2020. This was a prospective single-center feasibility study that aimed to explore whether baseline F18 FES PET discordance and FES fluoroestradiol uptake were correlated with outcome and response to concomitant therapy with AIs and a CK4/6 inhibitor. Now, these are two patients from the study, and both of them underwent pre-therapy FDG and FES PETs. So patient one was a patient who has a large burden of disease within the right axilla with concordant axillary uptake and a large burden of concordant disease within the skeletal system. So a large volume of osseous metabolic disease throughout the skeletal system, concordant what we see on the FDG PET. Post-therapy, and this was the interval was 8 weeks, we see a dramatic response to therapy. Now, patient two, comparatively, is a patient who has multifocal disease on FDG PET. Again, notice the uptake in the brain if you're wondering which is what, the absence of uptake within the FES study. But notice the discordance between the volume of uptake on the FDG PET and that which is seen on the FES PET. This patient was a non-responder 8 weeks subsequent to AI and CK4/6 inhibitor. So very importantly, and this comes up commonly in patients having Cerianna studies, is the interaction of endocrine therapies. So we know that endocrine therapies block ER and they reduce the uptake of Cerianna, and therefore they may reduce the detection of ER positive lesions after the administration of Cerianna. The two most common systemic endocrine therapies that we see in practice, of course, are going to be SERMs and SERDs, with SERMs most commonly represented by tamoxifen, which of course competitively binds to ER and induces conformational changes that alter transcriptional activity, whereas fulvestrant is a down regulator, and that competitively binds to and degrades receptors by increasing turnover rate. Because drugs such as tamoxifen and fulvestrant block ER and therefore may reduce the uptake of FES, the active component of Cerianna, a washout period is recommended for these for studies performed when patients are on these treatments. Specifically with tamoxifen, that duration is 8 weeks. For fulvestrant, it's 28 weeks. Now, comparatively, AIs, which deplete estrogen but do not interfere with the ER Cerianna or Cerianna binding, there's no reason to do a washout. So it's very important that you take very thorough histories of your patients when performing a Cerianna study. So let's move on. So, as we said earlier, biopsy may not always be feasible in metastatic disease where the breast carcinoma has spread to distant organs and multiple sites of disease. As we mentioned earlier in the talk, ER discordance occurs in up to 30% of breast carcinomas. Cerianna PET allows a more comprehensive assessment of ER positive lesions across multiple metastatic sites in a non-invasive fashion. Information garnered from this type of molecular imaging has the potential to inform clinical decisions and individualized treatment choices. So this is really game-changing with respect to being able to produce an in vivo map of ER positivity through a molecular agent. So let's explore some of the pivotal studies which demonstrated the accuracy of Cerianna and how it may inform clinical decision-making, as well as its utility in invasive lobular carcinoma. So let's begin by looking at Che's pivotal study, which was a non-randomized single-center cohort study to evaluate the diagnostic efficacy of FES in assessing ER status in patients with recurrent or metastatic BC and the safety of the molecular imaging with FES. The primary objective of Che's study was to show agreement between qualitative FES and the results of ER expression by IHC assay. So in his study, of the 47 patients who were ER positive via IHC, FES was positive in 36. All 38 patients who were ER negative via IHC showed negative F18 Cerianna imaging. So that resulted in a positive agreement of 76.6% and a negative agreement of 100%. Now, this data was built on by Curlin's meta-analysis. So this was a meta-analysis that Curlin performed that assessed published results comparing F18 PET and tissue assays of ER status in patients with breast carcinoma. For the primary analysis in Curlin's meta-analysis, researchers analyzed 4 studies that provided F18 PET lesion-specific information for non-breast tumors. So very importantly, non-breast tumors. And the primary analysis included 113 non-breast lesions, and ultimately with a very similar sensitivity and specificity to what Che had produced. So very important data that proved the diagnostic efficacy of Cerianna PET as a non-invasive adjunct to biopsy. Now, building on this is Boers in 2021, who looked at the ability of FES to resolve clinical dilemmas in ER-positive metastatic breast carcinoma. So Boers' study was a study that was aimed at determining the value of FES PET in resolving clinical dilemmas that remained after standard workup, which included either IHC assay of biopsy material and conventional imaging methods such as CT or MRI. A secondary objective was to investigate whether this imaging technique supported clinical decision-making for metastatic breast carcinoma management. So in a Boers study, there were 100 consecutive F18 PET scans, which were performed in 83 patients with confirmed or suspected ER-positive metastatic breast carcinoma. And there were three dilemmas which were assessed, one of which was equivocal standard workup, the second of which was determining the ER status, and the third dilemma was in cases where potential for more than one cancer was possible and understanding the lesion's ER expression might be informative. In terms of in terms of Bohr's conclusions, he demonstrated in his study that 87% of the patients that were enrolled in the study had a clinical dilemma that was resolved with the addition of FES PET. Moreover, those treatment decisions, 93% informed treatment decisions. So very, very impactful information. And moving on to Gary Eulerner's, and some of you may have had the opportunity to listen to Gary's talk with respect to invasive lobular carcinoma. So a couple comments about invasive lobular carcinoma. We know it's the second most common type of breast carcinoma, and it represents almost 10% of all breast cancers. Invasive lobular carcinomas are a different breed of carcinoma. They grow in a single file, and that makes imaging very difficult, whether that be mammography, MRI, or to some extent PET imaging, because of the inherent lower glycolytic rate of invasive lobular carcinoma. Eulerner's study in 2021 was taking data from a retrospective evaluation of 6 prospective clinical trials using FES PET in 92 patients with metastatic breast carcinoma, of whom 14, or about 15%, had ILC histology, and of which 7 of those 14 had synchronous F18 and FDG PET scan imaging, and that allowed comparison of the 2 PET radiotracers. So in the 7 comparable pair of scans, there were a total of 254 F18 avid lesions and 111 FDG avid lesions. Further, among a total of 268 osseous lesions detected by either scan, 94% were FES avid, but only 34% was FDG avid. Like all cancers, there tends to be some degree of heterogeneity. So there will be some patients whose avidity or number of lesions with FDG may outnumber those with FES, but nonetheless, the performance was fairly striking. So let's go through some cases in terms of Cerianna, some really great clinical cases that highlight how Cerianna can perform in clinical practice. So case number 1. This is a 73-year-old patient with a history of atypical lobular hyperplasia in 1997, right breast DCIS status post lumpectomy. The patient represented in 2018 with a left breast infiltrating ductal carcinoma, which was stage 1A, and underwent a left breast lumpectomy and sentinel lymph node biopsy. At the time of surgery, negative margins were obtained, negative nodes, and again, the pathology was infiltrating ductal carcinoma. In terms of pathology, low combined histologic grade, ER strongly positive, PR weakly positive, HER2 negative. This patient underwent whole breast radiation therapy and a trial of an AI, but that trial of the AI was discontinued secondary to osteopenia. The patient was then switched to tamoxifen. Physical exam in 2020 demonstrated a thickened surgical scar at the lumpectomy site, and the clinical question posed by the oncologist was, is this local recurrence of breast carcinoma? So moving backwards to 2018, at the time of diagnosis, we see an index image of the patient's mammogram, CC mammography demonstrating a small 1 centimeter spiculated mass within the lateral aspect of the right breast, identified by that arrow. Breast ultrasound performed at the same time, left breast 2 o'clock position, high resolution grayscale imaging with color flow demonstrates an irregular hypoechoic shadowing lesion concordant with the mammographic abnormality compatible with breast carcinoma that was diagnosed. In 2020, the patient represents with a mammography that looks like this. We have MLO and CC images, and we see marked thickening of the skin, and specifically marked thickening in the region of the lumpectomy. And this had been a change from the prior mammogram of 2019. Breast ultrasound performed at the left breast 2 o'clock position in the region of mammographic concern, correlating with the area of physical finding, demonstrated dense shadowing at the lumpectomy site, but no identifiable abnormality otherwise. Breast MRI was subsequently obtained, and in this case, the breast MRI, was demonstrated a rim enhancing or peripherally irregularly enhancing region and within the lateral aspect of the left breast, concordant with what was seen on the ultrasound and the mammogram. We have a MIP image which demonstrates the peripheral pattern of enhancement and with some sparing centrally. We look at the contralateral breast on the axial image from the MRI. We see no suspicious abnormality within the right breast. Similarly, when we look at the breast MRI in this case, there's no significant nodal disease within the left breast. And similarly, there is no identifiable disease otherwise within the left breast. Some imaging of the mediastinum as well demonstrated no mediastinal lymphadenopathy, and upper abdomen was clean. So This MRI was interpreted as being representative of potential recurrent breast carcinoma at the lumpectomy site. A targeted biopsy was recommended, specifically targeting the region of peripheral enhancement. Ultrasound-guided biopsy was then performed with pathology concordant with stromal fibrosis and fat necrosis, which certainly, based on the MRI, would be a reasonable, would be concordant to some extent. But because of the physical findings and the MRI interpretation, the clinical concern for recurrent breast carcinoma remained a differential consideration. FDG PET was then ordered to assess the lumpectomy bed and assess for metastatic breast carcinoma. So here's the FDG PET from March of 2021, and we have coronal MIP and coronal fused PET FDG images. Coronal MIP images demonstrate the lumpectomy site and a peripheral pattern of uptake, hypermetabolic uptake at the left breast lumpectomy site, but no significant uptake within the left breast otherwise, and the nodes on the left are negative. Interestingly, this patient had positive right axillary lymph nodes, which were anatomically normal. Clinical history is everything in radiology, as is high quality imaging and getting the right test. And in this case, there was a concern that these lymph nodes may in fact be related to COVID vaccination, but not something that would be necessarily easy to prove. And we're seeing quite a bit of that in March of 2021. Axial fused image of the same patient demonstrates the left breast skin thickening. And then as we move towards the lumpectomy site, we see the pattern of increased uptake within the left breast, concording with what we saw on the breast MRI and on the mammogram and ultrasound in the region of concern. So again, the question is asked on the basis of the FDG, we can't distinguish FDG positive metabolic neoplastic disease from a process that may be inflamed, such as fat necrosis. So the question becomes, how do we look at this again? Do we biopsy one more time? Because the biopsy may not be representative of what we're seeing on the breast MRI and or on the biopsy that was obtained. But rather than rebiopsy, we pose the question, perhaps Cerianna can help to reevaluate the region and distinguish whether or not the area of soft tissue represents fat necrosis or recurrent neoplastic disease. June of 21, Cerianna PET is obtained, and we have coronal MIP images from the Cerianna PET, and we have a coronal fused image. So the MIP image looks beautifully clean. We see the normal pattern of uptake within the vein. We see normal physiologic uptake, but very importantly, we see absolutely no uptake at the lumpectomy site in the region of previously demonstrated FDG uptake. No abnormal uptake is identified in the right lymph nodes that we identified as likely being related to previous COVID vaccination. There is no nodal disease otherwise, and there's no disease outside of the breast as well. So let's compare these images. So up top is the Cerianna PET. Down below is the FDG PET. We see that focal region of uptake at the lumpectomy site on the FDG PET from March of 2021. We directly compare the Cerianna PET, and we see absolutely no uptake, concordant absence of uptake at the lumpectomy bed on the axial fused image. Again, fairly striking uptake on the FDG PET, and then again the coronal coronal Cerianna PET image demonstrating the absence of uptake at the lumpectomy site in the area of concern. So in this case, what did we do? Well, we evaluated for recurrent breast carcinoma. We identified that the lack of Cerianna PET uptake, concordant with the biopsy, confirmed that this site is unlikely to be ER positive recurrent disease. No need to continue with a biopsy, no need to continue more directed imaging at that location. Similarly, Cerianna PET ruled out ER pathologic lymph nodes at the right axilla in the setting of recent COVID vaccination and suggested that there was an absence of ER distant disease. So very, very helpful for this patient in the setting of fat necrosis. So let's go to a different clinical dilemma. This is a 60-year-old woman with a history of left breast carcinoma. At the time of presentation, she had a 2.2 centimeter mass, ER positive, PR positive, HER2 negative. The patient underwent bilateral simple mastectomies in 2015. There was when the patient presented back to the oncologist as part of an annual exam, the patient was complaining of persistent lumbar and sacral pain. An MRI of the lumbosacral spine and sacrum was obtained, and the MRI, which we'll show subsequently, demonstrated a 1.2 centimeter left paramedian upper sacral lesion. And the question posed by the radiologist, particularly given the absence of any previous imaging, is this a focal suspicious marrow lesion in a woman with a prior history of breast carcinoma? CT was then obtained of the sacrum, and I'll show images from that as well, that showed no anatomic abnormality in the region of signal alteration identified on the MRI. So let's take a look at images, but first, I did want to mention also that the location of the lesion within the sacrum was not readily amenable to percutaneous sampling, and therefore, based on the concern from the MRI and the absence of an anatomic abnormality that was easily identifiable on the CT scan, we recommended doing a Cerianna PET to both assess for bone metastatic disease at this location and otherwise, as well as to assess for whole body metastatic disease. So going back to the, let me just make a quick change here. Going back to the MRI that was obtained in July of 2021, we see a coronal T1 weighted imaging, and we see a T2 hypointense lesion within the left paramedian superior sacrum, correlating with what was described on the report. Sagittal images demonstrate kind of a mixed intensity T2 hyper and hypointense lesion within the left sacrum, certainly not one that would be readily or easily accessible to sampling. So Cerianna PET was obtained, and this was in August of 2021, and we see, again, a very normal physiologic radiotracer distribution of uptake in the Cerianna study. Specifically, we see no evidence of bony metastatic disease with attention to the left upper sacrum, no evidence of disease throughout the skeleton, and otherwise no evidence of disease. So no uptake, clearing this lesion within the left sacrum. So let's talk briefly about how the clinical decision in this case was informed by a Cerianna PET. So Cerianna PET helped evaluate an equivocal bone lesion not readily accessible to percutaneous sampling, excluding disease at this site and otherwise. So we know that equivocal osseous lesions identified at conventional imaging may be particularly challenging to assess for metastatic disease, as biopsy may be technically challenging. And secondly, biopsy may be secondary to decalcification artifact, which must be performed in order to appropriately section a bone specimen. And this may then impact the ability to assess receptor status in metastatic breast carcinoma. So in concert with the clinical context, conventional imaging findings, and appropriate longitudinal follow-up, Cerianna may help to assess the ER status of equivocal bone lesions. So let's go to our third case, determining the ER status as an adjunct to biopsy. So this is a 63-year-old female with a history of an invasive ductal carcinoma of the left breast. Initial diagnosis of carcinoma was in June of 2019, and that disease was ER/PR positive, HER2 negative. Conventional staging at the time of diagnosis demonstrated pathological lymphadenopathy. Conventional imaging demonstrated adrenal nodularity, concerning for but not definitive for neoplastic disease, but no evidence of visceral or osseous neoplastic disease on conventional imaging. I'm just demonstrating the appearance of the mammogram here as she presented in 2019. We see an area of ill-defined density within the mammogram, which is fairly a large area, kind of an infiltrating type of lesion, almost non-mass-like to some extent, with a pathologic left axillary lymph node. We do the ultrasound, high resolution at that time. It demonstrates a shadowing irregular hypoechoic mass concordant with the area of palpable concern identified in the mammogram, concordant with the biopsy neoplasm. So conventional imaging performed, this is an example of a whole body bone scan. In this case, the whole body bone scan demonstrated only a focus of metabolic uptake, or scintigraphic uptake rather, at the left rib, and this was equivocal for neoplastic disease. No other evidence of scintigraphic uptake other than multi-articular radiotracer uptake. We're not sure whether this represents a focal metastatic lesion or alternatively something related to prior injury. So PET-CT scan performed in 2019, and that demonstrated the dominant mass as well as pathologic lymphadenopathy. We see what was normal benign thyroid disease, so I want you to kind of excuse that from your eyes, but what was not seen by the bone scan was multifocal osseous neoplastic disease throughout the skeleton, including a lesion within the left femur, which was subsequently biopsied, and because of artifact and sampling, turned out to be equivocal or non-diagnostic, regardless of the fact that the FDG PET was suggestive of multifocal metastatic disease. Low-level uptake was identified in the adrenal glands. So this patient then went on to have neoadjuvant ACT and had excellent response to therapy. We see that the dominant mass and pathological lymphadenopathy within the left axilla and left breast demonstrates marked response to therapy. We similarly see that the bony metastatic disease, and we can look at a lesion within the mid lumbar spine, demonstrates clearly decreased metabolic uptake, as does the dominant lesion within the left femur. So excellent response to neoadjuvant ACT in May of 2020. So as the patient is responding to therapy in August of 2020, undergoes an interval mastectomy. And at that time, there's low level or mild uptake at the mastectomy site. We see the continued presence of uptake within the thyroid compatible with benign disease. But again, at this time, no evidence of any disease in the axilla, no evidence of any visceral neoplastic disease, and no identifiable osseous neoplastic disease. So as part of continued surveillance in a patient who underwent the interval mastectomy and had a large volume of disease, in February of 2021, this patient represents for an additional PET-CT scan. And at that time, there is low-level uptake within small mediastinal lymph nodes, new compared to multiple previous exams, and indeterminate for the presence of neoplastic disease. No suspicious osseous neoplastic disease, and we see some low-level uptake at the mastectomy site, which at the time of interpretation was thought to be somewhat equivocal for the presence of recurrent disease. Discussion at tumor board occurred, a multidisciplinary board, and we said, well, potentially this is a great indication to look at Cerianna PET and see whether or not these mediastinal lymph nodes are in fact positive for ER, and whether or not there was a larger burden of disease otherwise, including reassessment of osseous neoplastic disease. So we have the FDG PET images on the bottom. Let me just make one small adjustment. Sorry about that, guys. We have the FDG PET images on the bottom, and we have the Cerianna PET images that were obtained in June of 2021. So coronal MIP and coronal MIP. These, again, were the lymph nodes that were identified on the FDG PET from the previous slide. Notice how striking this image is in terms of the volume of disease that the Cerianna PET encountered or uncovered in this patient in June of 2021. First and foremost, we see the nodal disease, and we see even greater nodal disease than was identified on the FDG PET. Similarly, we see osseous neoplastic lesions that were not precedently identified on the FDG PET. So ultimately, the Cerianna PET confirmed the ER positivity of the diseases of the mediastinal lymph nodes, but similarly demonstrated additional lymph nodes and osseous metastases. So let's compare these again. Okay, so FDG PET up top in this case, Cerianna on the bottom, and these are axial images and axial fused image. So this is a progressive right medial suprapubic lymph node on the Cerianna PET that's clearly positive and avid, and an additional small right paratracheal lymph node that was positive. Neither of these are seen on the FDG that was performed several months earlier. Let's take a look at some additional lesions. So we have this subcarinal lymph node, which was seen on the FDG PET, and concordant ER uptake on the Cerianna PET. But interestingly, we've included a lytic lesion within the mid-skeleton at the mid-thoracic spine, which demonstrated no uptake on FDG, but clearly was positive on FES. So FDG, positive node, negative osseous lesion, Cerianna, positive node, positive osseous lesion. So mediastinal lymph nodes were ER FDG, ER positive, FDG positive, osseous mets, ER positive, FDG negative. All the metastatic disease that was identified was ER positive. The potential clinical impact in this patient, consider endocrine-based chemotherapy based on the volume of disease all being ER positive and no disease being discordant. Completely concordant study. Similarly, the Cerianna PET can look at viscera. And we had mentioned earlier on that there was adrenal nodularity from the conventional imaging that had underwent observation with MRI, and the MRI suggested that this was benign adrenal nodularity. When we look at the FDG PET, we see that there's low-level metabolic uptake within adrenal nodularity, but comparatively, we similarly look at the Cerianna, and the Cerianna clearly demonstrates the absence of uptake within the left adrenal gland. So concordant with the fact that there is not ER positive disease within the left adrenal gland. So Case summary, Cerianna PET assessed the ER status of mediastinal lymph nodes and demonstrated a larger burden of disease than was expected by the precedent FDG PET. Osseous Mets, which demonstrated no significant FDG uptake, were demonstrated to be ER positive. Other pathologic lymph nodes were demonstrated to be ER positive, 100% concordance with respect to disease. So all the disease that we anticipated seeing as being positive was positive. So what are the potential clinical implications of Cerianna PET CT? And these are what we've discussed tonight. First and foremost, determining the ER status in recurrent or metastatic lesions as an adjunct to biopsy. Secondly, to evaluate the extent of ER expression in indolent tumors, what we discussed with respect to invasive lobular carcinoma, given invasive lobular carcinoma's inherent decreased or hypometabolic state. Similarly, and we showed a nice example of this, of identifying ER positive status in difficult to biopsy lesions, specifically bone metastases, but similarly and very importantly, brain metastases. Remember again, the absence of any native uptake within the brain with Cerianna PET. And lastly, Cerianna PET may resolve clinical dilemmas after inconclusive results from conventional assessments, and therefore support individualized decision-making in challenging clinical scenarios. Thank you very much for your attention tonight, and again, thank you.
Important safety information, indications and usage. Cerianna is indicated for use with positron emission tomography imaging for the detection of estrogen receptor positive lesions as an adjunct to biopsy in patients with recurrent or metastatic breast cancer. Limitations of use. Tissue biopsy should be used to confirm recurrence of breast cancer and to verify ER status by pathology. Cerianna is not useful for imaging other receptors, such as human epidermal growth factor receptor 2 and the progesterone receptor. Contraindications, none. Adverse reactions. In clinical trials evaluating the safety of Cerianna in patients with breast cancer, the following adverse reactions occurred at a rate less than 1%: injection site pain and dysgeusia. To report suspected adverse reactions, contact Xianexa US Corp., a GE healthcare company, at 1-800-654-1088 or FDA at 1-800-FDA-1088 or www.fda.gov/medwatch. For full prescribing information, click on or visit cerianna.com/PI. Indications and usage. Cerianna is indicated for use with positron emission tomography imaging for the detection of estrogen receptor positive lesions as an adjunct to biopsy in patients with recurrent or metastatic breast cancer. Limitations of use. Tissue biopsy should be used to confirm recurrence of breast cancer and to verify ER status by pathology. Cerianna is not useful for imaging other receptors, such as human epidermal growth factor receptor 2 and the progesterone receptor. Contraindications, none. Warnings and precautions, risk of misdiagnosis, inadequate tumor characterization and other ER positive pathology. Breast cancer may be heterogeneous within patients and across time. Cerianna images ER and is not useful for imaging other receptors such as HER2 and PR. The uptake of fluoroestradiol F18 is not specific for breast cancer and may occur in a variety of ER-positive tumors that arise outside of the breast, including from the uterus and ovaries. Do not use Cerianna in lieu of biopsy when biopsy is indicated in patients with recurrent or metastatic breast cancer. False negative Cerianna scan. A negative Cerianna scan does not rule out ER-positive breast cancer. Pathology or clinical characteristics that suggest a patient may benefit from systemic hormone therapy should take precedence over a discordant negative Cerianna scan. Warnings and precautions continued. Radiation risks. Diagnostic radiopharmaceuticals, including Cerianna, expose patients to radiation. Radiation exposure is associated with a dose-dependent increased risk of cancer. Ensure safe drug handling and patient preparation procedures, including adequate hydration and voiding, to protect patients and healthcare providers from unintentional radiation exposure. Pregnancy status. Assessment of pregnancy status is recommended in females of reproductive potential before administering Cerianna. Adverse reactions. In clinical trials, the most common adverse reactions seen occurred at a rate less than 1%, or injection site pain and dyschezia. Use in specific populations. Pregnancy risk summary. All radiopharmaceuticals, including Cerianna, have the potential to cause fetal harm depending on the fetal stage of development and the magnitude of radiation dose. Advise a pregnant woman of the potential risks of fetal exposure to radiation from administration of Cerianna. There are no available data on Cerianna use in pregnant women. No animal reproduction studies using fluoroestradiol F18 have been conducted to evaluate its effect on female reproduction and embryo fetal development. The estimated background risk of major birth defects and miscarriage for the indicated populations is unknown. All pregnancies have a background risk of birth defects, loss, or other adverse outcomes. In the US general population, the estimated background risk of major birth defects and miscarriage in clinically recognized pregnancies is 2 to 4% and 15 to 20% respectively. Use in specific populations continued. Lactation risk summary. There are no data on the presence of fluoroestradiol F18 in human milk or its effects on the breastfed infant or milk production. Lactation studies have not been conducted in animals. Advise a lactating woman to avoid breastfeeding for 4 hours after Cerianna administration in order to minimize radiation exposure to a breastfed infant. Pediatric use. The safety and effectiveness of Cerianna in pediatric patients have not been established. Geriatric use. Clinical studies of fluoroestradiol F18 injection did not reveal any difference in pharmacokinetics or biodistribution in patients aged 65 and over. Drug interactions. Systemic endocrine therapies that target estrogen receptors. Certain classes of systemic endocrine therapies, including ER modulators and ER downregulators, block ER, reduce the uptake of fluoroestradiol F18, and may reduce detection of ER-positive lesions after administration of Cerianna. Drugs from these classes, such as tamoxifen and fulvestrant, may block ER for up to 8 and 28 weeks respectively. Do not delay indicated therapy in order to administer Cerianna. Administer Cerianna prior to starting systemic endocrine therapies that block ER. To report suspected adverse reactions, contact Xinexa US Corp., a GE healthcare company, at 1-800-654-1088 or FDA at 1-800-FDA-1088 or www.fda.gov/medwatch.